Good afternoon, everybody. Thank you so much for joining us for today's speaker series. My name is Stephanie, and I will be monitoring things here on the back end. If you have any questions throughout the talk, you can either put your questions in the Q&A, or I will enable the chat so we can use the chat as well. I'll kind of keep an eye on those, and we can go through there. Just a reminder, I will be sending out an evaluation for this event. I'll put it in the chat later on today, and I'll also send it again tomorrow in a follow-up email. Please fill out the evaluation. We'd love to hear of other topics you're interested in learning more about. On that note, our next speaker series will also be virtual. It is November 19th from noon to 1. Dr. Natasha Nemmers will be presenting Aging in the Right Place, When to Stay and When to Move. So that should be a good talk as well. And with that, it's my privilege to introduce Dr. Vikas Kotagal. Dr. Kotagal is an associate professor of neurology at the University of Michigan and the associate chief of staff for research at the VA Ann Arbor Healthcare System. He completed his medical school at the University of Minnesota and neurology residency and fellowship in movement and cognitive disorders at the University of Michigan. His research involves designing and conducting clinical trials on Parkinsonian conditions that use brain imaging methods to overcome roadblocks in standard clinical trial designs and approaches for Lewy body disease. And he cares for patients with Parkinson's disease, LBD, and other Parkinsonian conditions. So with that, I will turn things over to you, Vikas.
Great. Thank you, Stephanie. And I will look to you for monitoring the chat, because I have to admit that's not something I'll be able to do facilely. But if questions come up, just either speak up or put them in the chat, and Stephanie can let me know. Thank you, everyone, for giving me the chance to speak here today. Like Stephanie mentioned, my name is Vikas Kotagal. I'm a neurologist at the U and at the Ann Arbor VA. I'm going to be talking today about falls and Lewy body dementias. I have slides. I don't have too many slides, so I would love this to be more conversational. If people have questions, I'd love to just talk about any questions that are on your mind. I don't have any financial conflicts of interest to report. I do have research that's funded by the Lewy Body Dementia Association, NIH, and VA as well. All right, so this is sort of an outline of what I hope to talk about today. Really three main things. So one, what is Lewy body dementia? I realize that this is not specific to the topic of falls, but this is an important question, and I think it's a question that needs to be, that we each need to ask ourselves when we're trying to understand how to treat symptoms that we think are caused by this disease and how to develop treatments for this disease. The next is about falls. How often do they occur in Lewy body dementia, and what causes them? And finally, how do we prevent them? Okay, so the first main topic I want to talk about is, what is a Lewy body? A Lewy body is an abnormal intracellular inclusion, like an envelope, filled with protein that stains pink in the center, kind of like a donut. I don't know if you can see my cursor here, but this is a Lewy body inside of a nerve cell or a neuron in the brain. They were first discovered by a neurologist named Frederick Lewy, who was a German neurologist. He was training under another neurologist named Alois Alzheimer, who you may know because of his famous last name as well. Frederick Lewy found on autopsy sample these Lewy bodies in people who had symptoms that looked like Parkinson's disease about 100 years ago, and described this this cluster. He didn't call it a Lewy body, but his colleagues went on to call it corpse de Lewy. And that name just kind of stuck for years. But for a long time, we didn't know what this was, whether there was something inside of it, what was inside of it. It turns out the thing inside Lewy bodies are misfolded proteins, a very specific protein called alpha-synuclein. Alpha-synuclein is a normal protein that's expressed in normal brain cells, and that's involved in the communication from one nerve cell to the next. It's a protein involved in helping a nerve cell secrete neurotransmitters that trigger the next nerve cell to fire, irrespective of what type of nerve cell those are. Uh, as as we age, our ability to break down break down alpha-synuclein, turn it into its component amino acids, and create new molecules of alpha-synuclein just gets slightly worse. The garbage truck kind of function, the protein quality control function, just gets less and less efficient. And that means that misfolded alpha-synuclein, which happens in everybody at all ages, just doesn't get cleared properly as individuals get older. That misfolded alpha-synuclein triggers other alpha-synuclein in the area to also misfold, and that all clumps together in a Lewy body. Um, Lewy bodies, interestingly, we don't fully know whether they are toxic or not toxic. They're so small that we cannot see them with imaging measures. We can only really see them on a brain biopsy or an autopsy. And it's never clear to pathologists or neurologists or neuroscientists whether Lewy bodies are a helpful development or a harmful development. And what I mean by that is that it's possible that alpha-synuclein misfolds and kills certain neurons. We think it does. But it's possible that the neurons that are dead really are not on the slide, the microscope, the tissue. We can't see them at all. They're gone. And only those neurons that are more um, solid and aren't susceptible to cell death, perhaps they're the ones that develop Lewy bodies. Maybe it's a sign of helpful compensation in the setting of misfolded alpha-synuclein, that you can smush all that misfolded alpha-synuclein into an envelope and the nerve cell can keep working. So it's very unclear about whether Lewy bodies themselves are a sign of um, pathology or a badness, or a sign of helpful compensatory function of a nerve cell. So Lewy bodies themselves happen pretty commonly in aging. About 15% of cognitively normal adults in their 80s are thought to have Lewy bodies on autopsy. I've seen figures as high as 25%. So it's roughly in that 1 in 5 range. And a lot of those are people who don't have any dementia or movement disorder or Parkinsonian conditions. And about a third of people with dementia have Lewy bodies, even if Lewy bodies are not the root cause of their dementia, even if they don't have Lewy body dementia. They can be incidentally noted to have Lewy bodies. So to some extent, the presence of Lewy bodies represents a sign of brain aging and brain frailty. What's a Lewy body disease? Now, this is just more complex. So a Lewy body disease, initially this term was developed as a neuropathological term to describe uh, the neuropathological diagnosis, that is the post-mortem autopsy diagnosis of an individual who had a neurologic syndrome in life, whatever the symptoms were, and had an autopsy finding with Lewy bodies. Um, it has kind of moved from the pathologist's realm into the clinical realm over several decades. Now we use this term as an umbrella term to include several different conditions. It is used to include things like Parkinson's disease and Parkinson's disease with dementia. It's also used to include and to describe dementia with Lewy bodies, which is just a reorganization of these words here into a different order. Dementia with Lewy bodies is even more common than Parkinson's disease. About 2 million Americans are affected by it, whereas Parkinson's disease affects probably around 1.4 million Americans. Collectively, uh, brains of individuals with Parkinson's disease with dementia and dementia with Lewy bodies really look very similar when looked at by pathologists. They have very similar brain findings when looked at on an autopsy level. And many people feel that we should lump these two conditions together, even though they develop differently during life. I think that some utility of lumping them together is that if we can understand common mechanisms that cause the formation of Lewy bodies in these different groups of people in the same parts of their brain, it's possible we can better develop treatments to prevent the development of Lewy bodies in people. There are some other more rare conditions, including multiple systems atrophy, that are also called Lewy body disorders. Uh, People have tried to use the term alpha-synucleinopathy as a synonymous word for Lewy body diseases because these are disorders of alpha-synuclein. It's such a long and sort of cumbersome word to say that most people don't say that. And we've kind of been stuck with the term Lewy body disease hereafter. So how is Lewy body disease, dementia different from regular dementia? I want to just kind of define some terms here because I think they can be helpful for understanding this contextually. When neurologists use the word dementia, we're often referring to not a disease process necessarily, but a level of disability due to cognitive impairment. So dementia, when I use that word, I use it in a way that aligns with something called the DSM-5, which is a diagnostic manual that medical providers use. And I use it to mean somebody who's had memory problems and at least one other type of cognitive problem, attentional problems, language problems, visuospatial problems, that's gotten worse over time, that's not due to a known structural lesion in the brain, like a stroke or a brain tumor, or a reversible cause that we've identified, like a medication side effect, and that's progressing to the point where it's affecting their ability to take care of either themselves, their work, or their social activities. And if somebody has an impairment in being able to do two of those three domains and has this clinical course, that to me is dementia as a neurologist. Now, the way I use that term in that way, I'm using it more like the way you would use headache or back pain. It doesn't tell you what's causing the headache or what's causing the back pain. It simply tells you what the natural history is of the process and what the type of symptom is that people are having. Most dementias are caused by neurodegenerative diseases. Um, the most common neurodegenerative disease is Alzheimer's disease. This represents about 50 to 60% of all neurodegenerative dementias. The second most common is Lewy body dementia, and that includes the collection of DLB, dementia with Lewy bodies, and Parkinson's disease with dementia. The third most common is frontotemporal dementia, and so on and so forth they go. So Lewy body dementia as a cause of dementia is a very common cause affecting millions of Americans. More into terminology here, but I just want to make sure that I'm defining the words I'm using properly when I'm using them, or at least conveying what I mean by it. I've mentioned Parkinson's disease, and I've mentioned Parkinson's disease with dementia. I'm going to call that PDD for short. PDD looks a lot like DLB, both clinically and neuropathologically when pathologists are examining brains under the microscope. Uh, the difference between the two in life is a pretty subtle and somewhat arbitrary difference that clinicians and researchers have kind of agreed upon and sought to revise year after year, but can never really come up with a better way of differentiating these two. So the difference is if the motor symptoms of Parkinsonism, slowness of walking, tremor, stiffness in the limbs, develop before the dementia, that's called Parkinson's disease with dementia. If the dementia symptoms develop first, that's called dementia with Lewy bodies. It's even more nuanced than that because it's not just a first and a last. It's if the dementia symptoms actually develop within 1 year of the onset of the motor symptoms, um, then that's called dementia with Lewy bodies. But if they develop more than a year later, that's called Parkinson's disease with dementia. And 1 year is arbitrarily defined as 365 days. So the idea that somebody at 367 days versus somebody at 363 days might have two different diseases depending on when they notice these symptoms developing seems fairly arbitrary. For whatever reason, though, this arbitrary categorization schema does seem to cluster with certain clinical traits that are a little bit more common in DLB than they are in PDD. Namely, people with DLB, dementia with Lewy bodies, tend to develop more sleep-wake cycle dysregulation, more fluctuations in cognition. They tend to develop REM sleep behavior disorder or a tendency to act out one's dreams during sleep and have vivid and violent dreams a little bit more commonly than people with PDD. So there is something to this arbitrary divide where these are two conditions that even though they look the same at the end of the day, they develop slightly different symptoms during life, and we still use this uh, categorization schema to differentiate these two. All right, so that's a lot, maybe more than you wanted to know about the terminology related to Lewy body dementia, Parkinson's disease, or PDD, and dementia with Lewy bodies. I next want to talk about falls and how often they occur in LBD, which I'm going to refer to as the collection of DLB and PDD together and what causes them. So we don't know a lot about falls and LBD. Actually, I did a little deep dive into the literature here. People talk a lot about falls in Parkinson's disease. People seldom talk about falls in DLB. And here are the things that I can tell you that I found in my search of the literature, is that falls are actually more common in prodromal, meaning in people who will go on to develop DLB, than they are in people who will go on to develop Parkinson's disease. These come from large cohort studies that assess tens of thousands of individuals and have them complete surveys and neurologic exams every year over decades of time. For whatever reason, falls seem to cluster with an early cognitive presentation more than an early motor presentation. Um, Fear of falling is a key clinical factor that differentiates one type of dementia with Lewy bodies, from Alzheimer's disease. And just over half, so the majority of people with DLB, will describe a history of falls the first time they see a specialist for evaluation of their underlying condition. So these are pretty common in people with DLB. Common causes of falls don't necessarily limit themselves to motor-related things or slow coordination. Lightheadedness is a common feature in DLB and Parkinson's disease. And in large studies, depression symptoms on survey assessments seem to also be a risk factor for falls. Um, why that is a little less clear. It might be because depression symptoms affect the amount of attentional resources each of us have. Um, Large studies also show that a greater degree of self-reported physical activity is a protective factor for DLB as well. In my own clinical practice, I find that these are common situations where people experience falls. So turning is the biggest one. Stepping up or stepping down on a flight of stairs commonly. Carrying something is really a very multitasking heavy function. It also involves displacing your center of gravity from where it was held previously, because it's often out in front of you if you're carrying something. Bending down, which again is a stress test for your center of gravity, sometimes also brings on lightheadedness. Reaching, doing household tasks, washing, getting dressed, which also involves often standing on one limb. Gardening, which typically involves walking on one foot or the other, or having altered proprioceptive input, sensory input from your feet up to your head. Um, that can be a problem. Getting in and out of bed, these are tasks that really depend heavily on the fitness and strength of hip muscles and quadricep muscles in your legs. Same with getting in and out of a car or a deep chair. And then the bath and the bathroom. This is a common spot for falls. I've seen at least some studies that have suggested that 40% of falls in people with DLB occur in the bathroom. There are a multitude of reasons for that. A lot of turns in a small area. Slippery floors is another part. Another thing is that after using the toilet, people can have a change in the amount of blood flow that goes to their GI tract versus to their head. And when they go to stand up, they can be more lightheaded at those moments. The same actually goes for bathing or using a shower. When you do that, your skin tries to dissipate heat by dilating its blood vessels, which robs the brain of some of the blood flow that it would be getting. And this is also a setup for relative lightheadedness that can cause falls as well. So falls in Lewy body dementia aren't just due to one thing. It would be more straightforward to treat them if there was a singular cause that we could point to. This is the thing. This is always the thing. But it ends up being a combination of a lot of different things. So motor problems, which are shown on the upper left portion over here. This includes slowness of movement, stooped posture, cognitive problems. This can sometimes include visuospatial impairment, so difficulty understanding where objects are in space or how close you are to a threshold or a doorway. Attentional problems can also impair one's ability to walk smoothly and not fall. Other medical conditions, so peripheral neuropathies, arthritis in your knees, these can all make you more prone to falling. Intrinsic physiology, which I'm using here to mean muscle strength, how strong your muscles are, and how quick your reaction time is as well. Extrinsic factors, so things like having a throw rug that you can trip over, or having a poorly lit room. And then medications. Many medications used in LBD care are, intended to be mind-altering medications for the better, not for the worse. But all of our medications have side effects at certain doses, and avoiding medication side effects that can increase um, slowness of thought and slow reaction time is a big part of fault prevention in the dementia with Lewy bodies. So many, I mentioned the motor parts. The motor components of DLB are linked to a specific type of brain change called dopaminergic brain changes, or loss of dopamine in the brain. Something about dopamine neurons makes them very susceptible to alpha-synuclein pathology and the development of Lewy bodies. Probably because they're very metabolically active. They're like extremely busy factory floors, and they make and break down a lot of alpha-synuclein. They have literally, a neuron might have 1 million connections. A dopamine neuron might have 1 million connections to other neurons about, supply chain areas where it's supplying dopamine or receiving feedback input from. So small um, things that cause minor degrees of inefficiency in those neurons can negatively affect the production of dopamine to a lot of different places. What a reduced dopamine in the brain leads to is the stooped posture, reduced arm swing when you're walking, reduced stride length when you're walking. It can also reduce the speed at which your eyeballs move. So if you're looking from your right to your left, or trying to move your gaze from your feet down to the hallway in front of you, it can be harder to initiate that eye movement, and the speed at which your eyeballs move can be slower as well. You can imagine all of those things can contribute to fall risk. As dopaminergic neurodegeneration increases over time, as disease progression moves forward in all of these conditions, people just live closer and closer to the threshold at which they're going to have falls with minor provocations. Maybe that's a mild stumble. Maybe that's carrying something and feeling off balance and losing your balance that way. Um, so it's not that it's the only thing that causes falls. It just pushes people closer to their compensatory threshold, and something else added on top of that can often tip the scales. Alpha-synuclein and Lewy bodies cause a lot of brain changes that are not related to dopamine, and that often go by the terms non-motor symptoms. And these can also cause falls. So I mentioned that one's working memory or multitasking function, your ability to shift attention from one thing to the next, is a big driver of falls. So too are visuospatial difficulties. Lightheadedness, I see that commonly. Fatigue is an interesting one, in so much as it's sometimes a manifestation of lightheadedness. Sometimes it's a cognitive symptom. Sometimes it's a manifestation of a mood symptom or a sleep symptom. But in all cases, it is very common in these conditions, and it leads people to want to move less. And when people want to move less, their muscles become slightly deconditioned and disused, and that puts you just at much higher risk of falling. Sleepiness, I mentioned. Oh
I
yeah,
have
please.
something in the chat, a
Yes.
comment. There's another cause of falls that my husband experienced prior to having a pacemaker inserted was heart pulses, which do occur with LBD. These were separate from his episodes of orthostatic hypotension.
Yeah, absolutely. So all alpha-synucleinopathies, and thank you for mentioning it. It's a good chance to talk about that. All alpha-synucleinopathies affect peripheral nerves before they start to affect the brain. And some of these peripheral nerves are in charge of maintaining heart rhythm. And when they degenerate, when they die off, people can be at higher risk for developing heart arrhythmias, extra beats, skipped beats, things of that nature. So that certainly is a common cause of dizziness and lightheadedness, even separate from the idea of orthostatic hypotension or orthostatic lightheadedness. And I use that orthostatic word to mean lightheadedness that's triggered by going from a seated to standing position or a lying to standing position. Skipped beats of your heart and an inefficiency in the heart's ability to squeeze blood flow out to the brain can clearly cause the same symptoms, but they're not necessarily driven by posture the way that orthostatic symptoms are. So that is, yeah, certainly another potential cause as well. Urinary symptoms, urinary urgency can often make people hustle to get to the bathroom and can put people in unsafe situations when they're doing that. Depression and anxiety are shown in research studies to be common causes or common correlates of falls. And I think one potential reason might be just because when you're thinking about something or your mind's on something else, you just have fewer attentional resources to pay attention to the environment you're around. And apathy has a similar negative effect to the fatigue thing that I mentioned earlier, which is that people become deconditioned more often. People with DLB or LBD also often have other medical things going on that are unrelated to DLB or LBD that also put you at risk for falls. Neuropathy is an age-related loss of sensory neurons in your distal feet and hands. It can manifest with different symptoms in different people. In some people, it can cause burning pain. In other people, it can cause a lack of sensation. So feeling like you can't quite feel the temperature of water on your feet in the shower. But a number of subtle reductions in the amount of sensory information that's getting up to your head. And that can put you at higher risk for falls. People often stand with their legs farther apart without realizing it because it gives them a wider center of gravity to compensate for the loss of those of peripheral nerves in neuropathy. So that's one of the first things that neurologists look for when evaluating a patient for fall risk is how far apart are people's legs comfortably when they're walking. And if they are farther apart than you would think is normal, it's often a prompt to do a detailed examination looking for a peripheral neuropathy. Arthritis of your hips, knees, lower back. These are big fall risk problems. Vision impairments. So whether that's macular degeneration, just a decline in visual acuity with distance vision, and any number of other retinal or intrinsic eyeball problems. Those are often a big part of fall risk as well. One common cause of fatigue that's a little different than Parkinsonian fatigue is cardiopulmonary fatigue, so getting short of breath when you're walking, having pulmonary hypertension, having heart failure that can just make you feel very physically ill when you are up doing physical activity. That can lead people to hurry and get in situations where they're at higher risk for falls. Medication side effects and home environment things are big pictures as well. And I've mentioned the deconditioning leads to atrophy of proximal leg muscle groups, in particular gluteus medius and gluteus maximus muscle groups, so really your hips and butt area. Those are really important for rising from a deep standing position, maintaining your balance when you're in single leg stance. And those muscles do atrophy and can get stronger if you exercise them. So this is definitely a modifiable component there. So how do we prevent falls in Lewy body dementia? On a medication level, we have a limited number of moves. Often we'll try to escalate levodopa, or sometimes I'll call it Sinemet because it's shorter, or other dopaminergic medications to improve speed of walking, stride length, arm swing, and treat the motor symptoms that contribute to falls. That can help some types of freezing of gait, though not all types. Paradoxically, at other times, we'll try to reduce the dose of that medicine depending on the person and what they're going through, because levodopa, a common side effect of it, is lightheadedness. It causes vasodilation, and that can lead to less blood flow getting to your head. That can be triggered either while you're seated in a sort of 24/7 kind of fashion or in an orthostatic sense when you stand up. People with tremor, people with Parkinson's disease, and people with things like depression and anxiety often get prescribed a number of medicines that have what are called anticholinergic side effects. So they reduce the brain's efficiency to multitask. And those kinds of meds can, of course, increase fall risk. So one of um, one of our charges as neurologists is whenever somebody comes in to look through their medication list and try to understand, are you on an anticholinergic medicine? If so, why are you on that? How important is that reason? Do the benefits justify the risks um, that it confers? Um, and then the corollary of that, or the flip side of that, are procholinergic medicines. So donepezil or Aricept, rivastigmine, galantamine. These are medicines that boost the amount of acetylcholine, which is a different type of neurotransmitter in your brain that in Lewy body dementias is thought to mediate attention and working memory. Um, Other than drugs, we usually use a common set of non-pharmacological interventions, and those include physical therapy. Physical therapy really aimed at strengthening those hip muscles that you use when you're putting on a pair of pants or making a turn when you're in single leg stance. That's a little different than the type of exercise that you would get if you're walking or running or doing a stationary bicycle, because physical therapy really aims to strengthen muscles that you don't necessarily stress even with regular long distance walking. It often depends on using a resistance band to strengthen hip muscles. So it has a value over and above, or in addition to, and also slightly separate from doing regular physical exercise, which keeps other leg muscles strong and keeps your cardiovascular fitness high as well. Studies have shown that for people at high risk of falls, medical management and physicians in particular don't do a lot. Using a cane or a walker, however, does a lot for fall prevention. And if nobody likes using a cane or a walker, but it's far better to use one and not fall than to not use one and have a hip fracture. Um, I think that socializing that concept, if you feel you might need it in your mind, carrying a cane with you on a few outings, just so you kind of get used to it, it can be a very helpful first step that way. And then finally, home adjustments. I think maybe my next slide might speak to that. Yeah. So what do I mean by home adjustments? I mean, making changes within your home environment where most people spend the majority of their time to prevent near falls from turning into true falls. So in the bedroom, that can mean bed rails. It can mean railings around the wall. One of the most helpful things often are motion sensor lights, which are the kind of thing you can get at Lowe's or Home Depot, but that activate when you get up in the middle of the night to use the bathroom so you don't trip over objects, or you can see, so you're less likely to trip over objects, so you can see what's there in front of you. Um, Within the bathroom, as I mentioned, that's a high risk area for falls. So a shower chair, grab bars, a non-slip bath mat, raising the toilet seat can make it easier to get on and off the toilet. And that can make a remarkable difference in reducing fall risk propensity after standing up from the toilet. And then other areas of the house, keeping like a grabber tool that's I don't know what the proper name for this is, but it's the kind of thing you can buy at like the dollar store that you squeeze it in. It has like a gripper on the end of it. So if something drops off the end of behind your couch or over somewhere, and you don't want to bend over to get it or have to put yourself in a physically challenging position to get it, this can help you reach long distances to get that. And then removing area rugs. I've seen a number of people advocate for stapling down area rugs to the ground or fastening them really tight. I I am sure that there's a rationale and a logic behind that advice, but my suggestion would be fewer rugs is definitely better for you if you can get around it, uh, given their likelihood of just causing falls in a rare moment where you might not pick up the front of your foot enough because you're thinking about something else or doing something else. So I'll close just by giving a summary here. Falls and Lewy body dementias occur both because of motor and cognitive deficits. Reducing unnecessary medicines that negatively affect the nervous system is a good way to try to treat them. And so too are using cholinesterase inhibitors like donepezil and getting medications like levodopa properly titrated. Using a cane or walker and making other environmental changes within your home are there should be something more there, but are key parts of what you can do to alter your fall risk moving forward. So I will stop there, and I'm happy to take any questions.
Thank you. That was very informative. We do have a pretty small group today, so if anybody wants to speak, feel free to raise your hand, and I can give you access to talk instead of just typing things in the Q&A or the chat. But if you'd rather do Q&A or chat, that's totally fine too. I'll keep an eye on those, and yeah, we'll open things up for discussion. All right.
Oh, yeah, great. Can I please recap the 1 year rule? Yes. I'm going to do it verbally, and then I'll go back to the slide. The slide is so kind of confusing. I tried to create a slide that would show it, but I think I just created more problems than I did solutions when I did that. So the 1 year rule is that if dementia, which is more than just saying mild memory symptoms, if significant memory symptoms start either before the onset of motor uh, symptoms of Parkinsonism or within 365 days after the onset of motor symptoms of Parkinsonism, that's called dementia with Lewy bodies. If dementia symptoms start 366 days or 2 years after the onset of motor symptoms of Parkinson's disease, that's called Parkinson's disease with dementia. So Parkinson's disease with dementia, dementia with Lewy bodies. Let me go back to that slide and see if that shows it as clearly as I would like it to, but I'm not sure that it did. So yeah, I think this slide is just trying to show motor features on the top, cognitive features on the bottom, and try to show when the time dementia started, which often follows the onset of the time where motor features started. And if this window here is fewer than 365 days, we call it DLB. If it's greater than 365 days, we call it PDD.
I have a quick question. If somebody's diagnosed with Parkinson's disease, will they automatically have cognitive impairments at some point in their life, or
Good question. The frequency, so the short answer is no. The long answer is that from the time of diagnosis to 10 years after that time in Parkinson's disease, the likelihood of developing dementia at 10 years after the time of diagnosis is somewhere between 50 and 80%. Okay. 50 and 80% is the majority of people, but it's not everybody. 20% of people will never develop dementia. And these numbers are confounded by the fact that people with Parkinson's disease often experience other brain changes that are unrelated to Parkinson's disease that can also negatively affect cognition. Things like strokes or heart attacks or other things occur in people with Parkinson's disease, just like they occur in people without Parkinson's disease. So that's why there's such a wide range between 50 and 80%, that likelihood there. So that's kind of the question to that.
Yeah, thank you.
And Ms. Steiner, I see that you were asking about Parkinsonism as well. So Parkinsonism is a term used to describe motor features of all these conditions: slowness of movement, tremor, stiffness of your arms or limbs, reduced arm swing, reduced stride length when walking. So it's a description, it's an umbrella term that encompasses the motor features of Parkinson's. So in my, I'm going to go back to sharing that slide again. In this slide, I I could just as soon say progression of Parkinsonism. Here I'm saying progression of the motor features of Parkinsonism, but they mean basically the same thing in this box up top. All right, next question.
All right. So I have one in the Q&A. What medications should be avoided?
What medications should be avoided? So there are medications that have anticholinergic effects are ones that we generally try to avoid. There are like 100 of medicines that fall in that camp. So I can't tell you that I can recite them all offhand. There's a if you Google Beers criteria, which I believe is spelled Beers, um, uh, Dr. Beers was a person who tried to characterize these medicines better. And you'll find that they are used to, and if you Google that, you might find a list of like 87 to 100 different medicines that are anticholinergic. Some are used to treat anxiety, some are used to treat tremor, some are used to treat a variety of different conditions. But it's worth looking into those things and seeing whether you're on any of those meds. And if you are, talking with your doctor about whether you need to be on them or not. So those are the main medicines to avoid.
Any new treatments for LBD or Parkinson's?
We're there are several new treatments for Parkinson's disease. They are reformulations of Sinemet or changes in the way Sinemet is given to people that prevent it from wearing off so quickly, and that have its effect last longer. Those things are good. They're very excellent for the right person. They, however, don't fix the underlying problem, which is the buildup of alpha-synuclein that's toxic to neurons. Um, Alpha-synuclein as a protein was really just discovered in 1997, so it's not that long ago, relatively speaking. And within the last 5 to 10 years, we've had the first small clinical trials trying to target alpha-synuclein and clear misfolded alpha-synuclein in nerve cells. So that's a major step because up until this point, we've been saying, okay, well, here's a new clinical trial, more Sinemet, less Sinemet, more of this drug that increases neurotransmitter, less of this drug. But what we really need are trials that ways to hit the real key thing that's causing all this downstream effect, and we're just starting to move those out. So it's a very exciting time for that. But no new disease modifying treatments that affect the natural history or prognosis are out for either of those two conditions yet. I see Miss Murray is asking about deep brain stimulation for Parkinson's disease. Is that something routinely suggested? Does it lessen fall risk? Ooh, I think in some people it lessens fall risk. In some people it can worsen fall risk depending on how advanced your disease is. So I have a hard time answering that directly. If your motor fluctuations, meaning if the cycling of going from an on state to an off state, to feeling like the medicines are working, to feeling like the medicines are not working, is a factor in your fall risk, deep brain stimulation can absolutely help that part.
I have another in the Q&A. Is falling the major in LBD?
Is it the major symptom? No, I mean cognitive difficulties are the main symptom in LBD. LBD has a lot of different symptoms. Unfortunately, it has a lot of different symptoms. Those include cognitive problems, sleep difficulties, mood changes, sometimes hallucinations and delusions, and paranoia, which we sometimes call psychosis, and then falling and motor problems as well. So all these are core parts of the condition, but I would say cognitive reasons are often the first reason that somebody will come and visit a doctor for that.
Great. Any final questions for today? I am going to just put the Qualtrics evaluation in here. I'll also send it out in a follow-up email tomorrow. So no biggie if you don't click on it right now.
Yeah, I think that we're all set. Thank you so much. That is very educational, and glad we got to bring you in for Lewy Body Dementia Awareness Month.
Oh yeah, absolutely.
Yeah.
All right. Well, thank you, everyone.
Yeah. Thank you.
Bye.
Bye.